7:03 this morning, and we had a walkthrough from Commerce, and I believe on more than one occasion they deferred to your committee, and you in particular as the person we really should hear from. So here we are. And do you have a bill passed the House in front of you?
I do.
Okay, so can you help us just go to the right sections where we start, and you're going to give us an overview how you want to proceed?
Great. Yes, section 19 would be the beginning of the healthcare workforce section, and it goes through to section. I've got the whole.
So what page?
That would be page 33. And it goes through page 53. Section 33.
A lot of the nurses stuff.
Yes.
Sorry, this is 7:30.
Yeah, you can kind of go right at it.
It's always helpful to know what the intended to know.
Oh, we're at 7:03 and I have 7:30, so I apologize. Gotta go get
7:03, yes.
Okay. We're on page 33, section 19. Take it away, however you want to proceed.
Thank you, Representative Van Donahue. If it pleases the chair, I could just give a high-level overview of what are we focused on,
I would like that.
and then sort of how that played out in terms of the specific parts of the bill.
Good.
So the Commerce Committee requested that we provide key input on the healthcare workforce part of the bill. And we actually worked a lot of the time, 3 members from healthcare with 3 members from Commerce jointly. After our committee took all the initial testimony, then we really had a work team together that fleshed out more of it as we went along. We really thought that there were 3 kind of areas that needed focus. The first was the mental health workforce, the level of crisis across the mental health system, which is sort of most highly evidenced to everyone in the emergency room. Waits, which connects back to if people can't see a therapist for 6 months, they're going to go into greater crisis, etc. Secondly, the nursing crisis, which has become very evident and had a lot of attention. But one of the issues we also looked at is the healthcare workforce as a whole, because over the years in the healthcare committee, there's sort of a sense of whack-a-mole. Each year, it's this group that gets the attention as urgent, and there are a lot of areas that have serious workforce shortages. So we didn't want to say, well, let's just look at nursing and mental health and not worry about the rest. There's a real need to pull the picture together and be able to know where are the strangleholds, where are the biggest problems, so that we can do better planning down the line. So the mental health piece was shifted into the appropriations budget, and that's why you don't see it in 703.
So sorry, mental health ended up where?
In the big bill.
I'm just curious, why was it pulled?
Because our recommendation and focus, and actually as the bill came out of Commerce, was that the most essential need in the mental health workforce was increasing the rates for the designated agencies and restoring or adding money to the scholarship program for designated agency staff. So therefore, those 2 pieces were moved. The appropriations committee moved them into the budget. There is still one small piece that has to do with improving the licensing process that's in this bill that relates to mental health, but the primary pieces were.
What kind of money are we talking about in the budget?
Well, we were asking for a 10% increase, which I think was in the ballpark of $46 million, but that's global commitment as well. Our appropriations committee really struggled. The governor had proposed 3%, and the big bill as passed the House has a 7% rate increase.
So what is that, like about 30 million? And that's gross? State shares.
Right, 30 or 35, yeah. Part of the problem was we were our committee's healthcare, you got the split jurisdiction problem because human services
Right.
has the other part of that system, and the designated agency said, well, we can't bring our mental health workers up and then leave our developmental disability workforce, which is just as desperate, and not with them. And that increased the price tag a lot, which to be inclusive, and human services sort of came to us and said, you can't leave us out, just this committee. So that, yeah, that was part of,
So if I had to write down a general fund number for increasing wages for DD and mental health, what would that be, you think?
I can get that for you right away. I didn't take that on the top of my head. But we have a little chart, so.
And those are principally wage increases.
Those, yeah, that's right. That is in order to enable wage increases.
So as we're trying to figure out how to merge workforce and economic development, would you consider, in some ways, this is definitely workforce improvement to get more money in people's pockets, but it's not like, it's different than scholarships or taking classes and stuff like that.
It is. There was a scholarship component as well, and I think there probably was some miscommunication. I don't know if I'm supposed to say in testimony that the House had miscommunication
It's okay,
internally.
we happen to.
We're pretty fine.
But we included, there had been a scholarship fund established for mental health, with the return working component. And it was delayed year after year, and we finally moved it directly to be allocated to the designated agencies to move it faster. And the money didn't finally actually start flowing until I think November. So by appearance, when the bill got to appropriations with $6 million reserved, they eliminated it, saying there's all this leftover money still in it.
Oh.
Well, it was left over because people were just like rushing to apply for it. So it was technically still there in this year's budget, but it's not going to be there.
So is that something you're readdressing with your approach for the conference committee?
My impression from our appropriations committee is that, they felt the budget was so starved, they're going to be responding to things the Senate asked for. They're not going to be adding anything at this point.
So if
for
it's
discussion.
if it's to be considered, we should
So the
be
mental
considering.
health scholarship program is not in this bill, and there's no new money in the budget bill.
Correct. That's correct.
So if it's dire, we should be looking at it.
That's right. And of course, Julie Tesler's the point person on that. And
Right.
after it was eliminated, she came back and said, people didn't realize the only reason it appears to still have money in it is because the money just got released to us. And there's a huge uptake, and it's going to be gone very quickly now that we finally have the opportunity. I mean, they have in some areas a third of their staff vacant because so many people. I mean, that's the level of the workforce crisis.
And that's a scholarship program for people who are not working in the field yet to take courses and stuff.
No, that's for I believe it's both loan forgiveness and scholarship.
And we've learned the difference here.
Yeah, and it's for people who are currently working in the DAs for retention and for internal growth, because that's the big loss. We had things going on. The crisis respite program in Chittenden County for children, for diversion from the hospital, which is a 24/7 program, they eliminated the weekends. They were just running 5 days a week. They didn't have staff to keep it running.
People don't have crises on weekends.
Right.
Yeah.
Well,
No, you're not allowed to. Who administered the scholarship program?
the designated agencies
Oh, so they.
through DMH. And part of the struggle was we transferred it last year to say it has to come directly to the DAs because the system is not working to get the money. So DMH then said, okay, we're giving it to the DAs, but here we're setting up all this criteria and things like, so they still put this big, which slowed it. It's still, this was $5 million from the Volkswagen settlement way back. It dropped down to 2 million because the money was still there. So every year, of course, what do we do in the legislature? Oh, look, unspent money.
So,
So let me ask you a basic question, maybe you can help me understand, because I'm still struggling with it. There's been a paradigm shift in the Senate, and I think it's been because the House has asked that it be done this way, is that we used to send bills out of here with money,
Yeah.
knowing full well that appropriation was going to strip it, and then put all the things together and decide what their priorities were on the budget.
Right.
And we understand the House wants to go back to the old way where the money's in the bills. And in this bill, there's $26 million. But now you're saying the mental health raises are in the budget. Well, where's the line as to what goes in the budget and what goes in the bill?
You're way above my pay grade.
Okay. I just thought I'd ask. You usually have good answers to everything.
I know
So not a
that
bad
I
answer.
know that we're frustrated. We were dealing with a bill right now on certifying, peer, mental health peer staff. And there was no money in our budget to do it. And they're saying there's gotta be this, but the Senate sent it over without money. And we don't know if the Senate's planning to put money in. And if you're not, then we're not gonna bother with the bill, right? But
It's really confusing.
it is very confusing.
Is there any thing in the bill that relates to expanding the mental health staff or bringing new people in?
Only through incentive by having more competitive salaries, because they're not competitive at all. So that's been the focus for mental health right now.
Competitive to what?
Well, competitive to similar, well, not even private,
Burger King.
hospital, well, we're looking at just education system, hospital system. If you can make a lot more money in one of those other healthcare system components, you're not gonna stay in it.
Well, is there any guideline in terms of what this means for a person doing job A compared to where they are now and what they will be in what's planned here? Was there any scheduling done or anything of that nature?
There is information, and I think Julie Tesler is the one who has most of that information in terms of the comparisons and, you're talking about master's level clinicians who, make very low salaries in the designated agencies system.
and those, anyone who has an MA could hang out their own shingle, which
Yes,
is what they're doing and getting paid much more. And so,
This is a multi-year effort, right?
oh yeah, it began with Tim. Do
Absolutely.
you remember Tim? This
Tim
was
was
one
a
of
big-
Tim Ash's big
And-
pushes
and
was to.
yes, it's a multi-year problem. It's increased and built up over the years. The Hospital Association is lobbying desperately for the designated agencies to be rebuilt because they've been underfunded for so long. Because from the hospital's perspective, they're ending up having to deal with the volume of crises because people aren't getting the interventions of the community.
Right.
And they're often having people stuck in the hospital because they can't discharge them because the supports don't. If you don't have supported housing and a person's just gonna be discharged to go home and they're not gonna make it.
So in terms of the year-to-year increases, is there a plan, is there some sort of commitment that's been made? Like just every year we come in and say, we've got to keep working on this problem?
Unfortunately, that's,
Well, it's been pretty good in terms of keeping that commitment, right?
No, well.
Wasn't there talk?
there was way back, it was one of the early years I was here, it was Jim Douglas. At one point, there was a 3-year commitment that helped move it forward, and then that was it, and then it went back to, fight every year for getting small increases
Yeah.
that don't keep up.
Yep, we are now significantly.
Okay, well, that's a good start. We're still on page 33.
Right, we
Well,
haven't started what ended up here, this is what got cut out.
You were doing a great job in terms of framing the issue. I don't know if you want to continue along there or you want to start jumping.
That just ask.
Well, just 2 quick others where these things came from, so.
But also, just the frame up. The third one is the healthcare system overall. So we have
Yes.
mental health, nursing crisis, and that's sort of the big picture healthcare problem.
That's right. And what we relied on most significantly, along with testimony, of course, in terms of the workforce overall, was the strategic plan that the administration was due to provide and did provide. It was a large work group, and it actually has 40 points in it. And you look through it and say, we could get a long way if we actually did all of this, because it really was cross-cutting. Some of them were things the legislature could and should do, and some of it ended up in the bill. But a lot of it has more to do with getting information pulled together, like data that can be analyzed, and connecting people and following through on these things. And that ultimately shows up in the bill in terms of creating a position for a point person who does all that work, so that it doesn't just have a big plan that then, you know, never gets followed up on. So that's the broad picture. There are a couple others. And then the nursing piece, it was really a pleasure to work with Senator Sanders' office, in part because we didn't get a meeting with his office until we had finished a lot of our testimony and kind of had our ideas in mind of what needed to be done. And when we got the letter from his office and met with his staff person, it was so much in sync with what we had done. We were sort of ecstatic. We didn't have everything in the plan that was being recommended, but everything in our plan was a piece of what was being recommended. So that was very gratifying.
He should have been ecstatic.
Well, I'll tell you, you want to know what made my day that day? We were in a meeting with his lead staff person from Vermont, and so she was engaged with our work group, and she said, oh, she had to interrupt to take a call because it was the senator, which, you know, we would do. She was off for about 30 seconds and came back on and said, oh, he said this meeting's much more important. I can call him back. Well, that's not.
So, but where is his plan? I mean, his plan hasn't passed the federal.
No, it's his really recommendations. You might recall there was actually a press conference with
Becca was in it.
Becca and Jill and the governor together, focusing on the nursing. This is all focused on the nursing workforce. And we had the press release. We were having a very hard time saying, where is the actual plan? And that's what we did finally get. And that's when we met with their staff person. And I know you're going to probably ask me for her name.
It's on the witness.
Yes, it's on the witness list. I'm terrible with names. But at any rate, so we do have that, the actual plan, which is really just a list of recommendations of what the state should be doing. There are some pieces.
As opposed to what the federal government could support.
That's right, yeah.
Yeah, so just on that, did you find that maybe funding or moving forward on something that's duplicative or inconsistent with what the feds might do? I mean, if they're about to unload a boatload of money on us, should we know that, or? I mean,
Yeah, because of the relationship with what the work they were doing, and they actually met with and with some of the same people we did. They have their kind of witness list, so to speak, and the letter identifies some of what the federal government's trying to do, but lays out this is what these are the state pieces that we think you need to be doing.
Okay, good. Because when we find that the restaurants are classic, you know, we're trying to get money out the door to people, and then all of a sudden we hear there's a restaurant revitalization fund coming down. So that's money that we could use towards other things. We just don't want to trip over ourselves with the federal.
Right, I think that was what was so helpful about this link. So that's the overview. That's how we focused on what we focused on. And as I say, the nursing pieces, which is probably the largest part, certainly the biggest part of the money in our recommendations, came out of a desire to really focus on increasing the throughput for new nursing. What we found is that our state nursing schools are turning away applicants. It's not a lack of applicants. They don't have the capacity, and there's very specific reasons they lack the capacity. And they really pin down to a couple of key things. One is, of course, people who can't get the scholarship and loan repayment pieces. But one of the big ones is the clinical faculty at the schools. they can't attract them because they are paid so much less than that same nurse going to a hospital, would increase by a third their salary. So they're having a real struggle with that. There is a lack of what they call preceptors in the hospital and healthcare system. A nurse who's going through training needs to spend time in the workplace settings with for instance, hospital nurse who's taking them, come along, you two students, follow me for the day and I'll show you how we do this. Those nurses don't receive any additional. Some hospitals try to give them a little extra reimbursement for it.
The mentor or the?
Yeah,
The mentor,
They're
we're talking about the
basically mentors. I
mentors.
wish we used that word.
Hmm?
But
They're basically mentors. They're called preceptors.
They're actually clinical nurses on the floor.
Yes.
That's correct.
Is the mentee or the student, aren't they required to get their license to have time on the
Yes.
floor?
Yes, and that's the problem. If you don't have enough of the mentors willing to do it, and it's gratuitous on their part. So this was one of the Sanders recommendations, one that we hear a lot from the nursing schools. So that's a piece as we go through that you'll see.
Gratuitous.
Yeah.
So do doctors get paid more when they have students following them around? I don't think so.
We did not, because of, time focus, in terms of the specific proposals here, we were focused purely on the nursing. And then the bigger strategic plan for now, you have to put together what we need in everything else, because we can't just keep doing, okay, what's happening with doctors, what's happening with primary care, what's happening with, so we really focused on the nursing.
So the preceptors is a big piece of your money.
It is,
2.4 million.
yes.
And I've heard varying thoughts that is effectively spent here. That those who are going to be willing to have students go with them are willing to have students go with them, but they don't need to be paid more.
Well, we know that we have a shortage of them. It's something that Sanders' office recommended, something that the hospitals are the ones who gave us the figure in terms of, we think kind of the minimum that would make a difference would be a $5 an hour differential. In other words, supplementing their staff.
Which is what the 2.4 is. It's
That's
$5
right.
supplement.
Yes.
But it would be curious to know what the expectation of a clinical nurse is, just like a clinical doctor. I mean, if you're in a teaching hospital, isn't that just part and parcel of your job?
These are not teaching, there's one teaching hospital. These are across the healthcare system. These are all of the hospitals. So I think that makes a difference. And ultimately, and we also asked for a sort of a work group to look at all the other settings. These nurses don't just have to have time in hospitals. They may be going into primary care. They may be going into schools. They need those other locations. So you can't do it all, but when we walk through, you'll see there's a segment about getting people together to look at how we support getting more preceptors in place
The
elsewhere.
nurses who are in training, are
Yes.
they working at the hospitals in which they have preceptors, or are they there solely for training purposes?
They are working in those hospitals under the clinical nurses. Now, they've got their educational component. They have these very expensive simulation labs. They practice putting a needle in a dummy before they practice on your arm, which is good. But then eventually they have to practice.
I've played the dummy several times recently.
And just a question on that $5. When a preceptor, I'd rather call it mentor. A preceptor means nothing to me.
Okay.
But I know now that, so a clinical mentor, is the $5 an hour for the whole year? Is that just a $5 an hour, or just when they're being a mentor?
It's just when they're being a mentor. What we did is calculate the number of preceptor hours needed for the students. So we weren't calculating because, maybe one nurse is going to do it. Yeah, I don't even know the details of how they work it, say, in a hospital. One nurse may be just doing one shift a week, another nurse may be doing it all the time. So we were looking at it in terms of what are the numbers of mentored hours that a nursing student needs in-hospital supervised time. And that was the figure that was multiplied by the $5 an hour to identify the 2.4 million. So we worked from the nursing student end.
And did you, and sorry to be a sniggle on this, but I've just heard that this was one of the cost things we could actually remove. So I'm curious to hear its why keeping it. So I would be curious to know if in a teaching hospital, this is expected of nurses as opposed to non-teaching hospitals like Mount Scottney or Springfield, where it's not. So it would be interesting to find out what the job expectation is at UEM versus Mount Scottney. And if this actually would make a difference, it is like gravy and unnecessary at UEM versus a place like Mount Scottney. You see what I mean?
Yeah, I understand the question. We didn't hear any distinction from the hospitals or the nursing schools. That doesn't mean that there isn't one if it was questioned further, but our sense was very much that it was needed everywhere, that they're not getting anything additional for those positions, and not all of them do it. It is a voluntary, it is voluntary on their part to take on students.
So you started off by suggesting that going backwards, the reason to do this is that nursing schools can't take in as many applicants because they can't fill this preceptor or mentor. So I'm going to ask the Senator Brock question. At the end of the day, are you going to be able to show that nursing schools have increased their enrollment as a direct result of this?
That as a direct result of four specific investments. So there's four pieces, and all of them relate to a focus on that throughput, getting more nurses and counting the nurses. One of them is the preceptors. Another is the faculty salaries, and all of these are many of these are bridge programs. Like this is a 3-year piece that you've got to start building in. So they're not permanent. The third one was moved to our capital bill. I'm speaking to your institutions committee, and that was for the simulation labs that need expansion if we're going to increase. They don't have the capacity for more students because of that. And then the fourth one is what's the pipeline program, where there's been incredible success in 2 places. One in the long-term care facilities, and the other, Central Vermont Medical Center, has a pipeline program where they take their own staff who are in lower level positions. Maybe they're working at the nursing home as a care assistant. They're already committed to the field. They're working there. They would like to grow. They would like to upskill. They've got a family. They can't take off time for classes. They can't, they've got all these other pressures. And so the hospital created a program where they connect the student with scholarship funding, and they pay them for some of their school and homework time. They continue to pay them a full-time salary while they work fewer hours in their clinical job. So that package together has enabled students to make their way up and become homegrown, going from internal advancement. But Central Vermont, for example, and the Nursing Home Project both had some grant funding to get it started. And so the idea of this program is to make grants available together with any healthcare. It's not just hospitals, any of these healthcare agencies, to be able to say, we will create a program, we will apply for a grant, we will put some of our own money in, we will then sustain it. And if you think of the time it takes, well, it takes 2 years to get an LPN, 4 years for an RN, but they're spending a fortune on travelers. Our thought is that if we get this going, because of this lag time, that they're still paying for travelers. They can't say, well, we'll put the money from travelers into more support for this, for educating some of our upskilling. But if we help get these pieces started, they'll start getting these nurses, and they will be able to maintain the commitment to the program after it's initiated. So that's the concept for that program.
So just getting back to briefly to the federal question, it strikes me that in a global sense, we all know we need more nurses in the field. Is there anything the feds are doing to address that problem?
I don't believe there is currently, and I checked the Senator Sanders memo, which does not suggest that. I'm just, because I don't remember there being. He identifies each of the problems: insufficient preceptor slots, costs and availability of education, insufficient pay for nursing faculty, each of those things that we said, oh, and that's what we concluded as well. So, no, he was not suggesting that there was any federal support coming for it.
Well, it's a great starting point. Do we want to go through the sections, or we touched on a bunch of them already, but
I have mostly on the nursing. There are some that probably appear pretty discrete, but are actually mostly in relationship to the strategic plan directly. And I'll just give one example. There's a piece on continuing the work on prior authorization. And that actually was in the strategic plan as part of one of the pressure points that is, bringing our healthcare workforce, when we've heard this for years, the administrative cost burdens of these prior authorization systems. And we, as a legislature, have had initiatives to try to get the Green Mountain Care Board and so forth to dig into what can we do to reduce them, to streamline them so that they're the same, to reduce that burden. But it came out of the workforce plan. And so we have a segment here on a continuation of that work that the Department of Financial Regulation is going to be doing. So those are examples, so we can walk through, and I have as much time as you'd like, but we can look, at each topic area, and I can kind of answer questions or.
why don't we try and do that for the next 15 minutes?
Sure.
It's a lot of pages, but we don't need to go into the weeds too much. So.
Right, and some of them, because they're putting a scholarship program in statute, there's a lot of language that's the statutory language rather than kind of what's the bottom line. So really the first one, section 20, is the nurse faculty support. And that was based on the figure of $10,000 per supplemental to each nurse faculty position, calculated on 3 fiscal years. And again, that's that concept of being abridged, right?
For 3 years.
Yep. And then section 21 is the Preceptor Program. And that's the hospital, the 2.4 million for the hospital. The second part of that fee is about a working group to be looking at how do we increase those clinical placements in other healthcare settings, because it's not just about hospitals.
Is this also a bridge program envisioned for 3 years? With
I
2.4
never
million?
heard that.
Because I know in the first
No,
one,
this
specifically cite fiscal year 23, 24, 25 here.
Right, this one is 1 year only.
So what do we do after 1 year?
There's a lot of built-in saying, we're helping you get over this hump, and part of it's COVID, the stressors on the hospital.
And the traveling nurses, once we're done with hemorrhaging on paying for traveling nurses.
Exactly. If we can help you get through this, you're gonna have to pick up the pieces after that to continue it. And some of it was, we were balancing what, probably the single biggest other thing that we were being pushed for was subsidizing, if you will, increasing clinical nursing salaries. And we said, you know what, that's the hospital's responsibility. That's not something for the state to step in and subsidize that. But, so we were trying to parse out that, what is something that we can be doing to help bridge this gap. The section 22 is what we just discussed, the pipeline and apprenticeship program.
I've got two questions about that.
Yes,
The first is Jill Olson from the Visiting Nurses, I understand, has spoken with you.
Yeah.
Okay.
I have a little note here saying, mention that we didn't specifically reference home health agencies, and it's probably worth specifically
So
mentioning.
specifically mentioning in the list in
Right.
section 22.
Right, she's concerned about them being forgotten if they're just left as other healthcare, and that makes sense.
Okay. Then the second question I have is when DSAC was in here, they said that they didn't believe that this was a good fit for their skill set.
Right.
Do you have any thoughts about that?
This is the problem when you're kind of good at what you do. When we look at the different potential, there's AHEC, which tends to be slower sometimes on getting things out. They do the job well, and the Department of Health didn't feel they had the infrastructure. So that was sort of our call that they were best suited among. This is different from, we haven't had a program like this before. It's not a scholarship, it's not a lumber payment. So some of these newer programs, we were trying to figure out what fit best. And so that's where we ended up with that.
AHAC isn't really under the state's control, is it? So assigning to them would not be
Right.
a logical, if we want to get it done.
I would consider DSAC in the state's control either.
Yeah.
Well, it's not, but it probably has, we probably have more influence with that than we do with what essentially is a federal creature.
So, and that was also one, just to tag on to Randy's question. We were unclear which AHEC, there seemed to be a number of different parts of AHEC. Which is the AHEC that runs all of Vermont? So I mean, who?
Or doles out the
Or,
funds. Because what we heard yesterday was it might be UVM's base, UVM Medical AHEC that distributes
But it's
education
unclear.
funds, but there's a Northern Vermont AHEC and a Southern Vermont AHEC.
My understanding is AHEC is all through the University of Vermont. They may have sites.
Okay.
But I can't,
But that's the whole, all of Vermont.
yes.
Yeah,
It
that's a,
said there's a Vermont AHEC network and then it named all three. But we did hear that UVM's might be the only one that distributes education dollars, which seems like it would make it the important, one for the purpose of, health education. But maybe they administer the funds or something through it.
Well, and I believe they were the ones that wanted to focus on, high school, middle school, encouraging, doing more of the work they currently do. And we ended up, among the competing things, thinking that staunching the bleeding in the most urgent areas should come first. Not that there is value in what they were suggesting.
yeah. So one of the things I think, one of our general takeaways from the first Charlie's overall presentation of this incredible bill was that nursing, which has one of the most successful ladders of attainment, it has one of the clearest ladders of credentialing and attainment, where you are, what you get, blah, blah, blah. Really good. There's no one body overseeing this octopus of opportunity. I mean, so to have all three different players here on nursing, Department of Health, AHEC, BSEC, it just strikes us that there needs to be one entity, and OPR, I think, does OPR
And
license?
OPR, no, I think
And I think we need one head that oversees all these pieces.
And that's what the strategic plan, a lot of their pieces talk to that there is so disparate.
Yeah, you said, and so
Yes,
what do we do about that here? How do we help that here, and who can we get to be, I mean, it strikes me that the Department of Health is the one, state player here.
we identified the Office of Healthcare Reform in AHS as the place where that needs to be pulled together, but not restructuring it this year, but to pursue all of these different components of a plan that says, they're bullet number 2, integrate the Healthcare Workforce Strategic Plan Advisory Group with the State Workforce Development Board, even between healthcare and other workforce. I mean, they have such a list of these things need to be pulled together. And so we said the Office of Healthcare Reform ought to have somebody who is focused on pulling this together. And then we can be asking next year, so based on this, where are the overlaps? What do we need to do to restructure? Because we didn't think restructuring was really viable this year.
But one of the challenges we face in looking at all these different pots is we feel like there is overlap, just like we feel like there's overlap, well, anyway, there's overlap all over the place.
Yeah.
And how do we not waste precious dollars? I think that's one of our concerns looking at all this.
And I think you have a tougher job than my committee did, because we were looking at the healthcare workforce, and the rest of the bill has all these other workforce pieces, and those are all in different places as well. So it adds to that issue that you're seeing when you have a whole bill.
Or could we not, I don't know, Office of Healthcare Reform, I don't know your world well enough to know, that's embedded in Department of Health, right?
No, it's embedded in the AHS so it's in the AAH, so it's above the Department of Health. It's the central structure.
Oh,
So it can then delegate pieces of that work to the Department of Health. They're part of the Secretary's office, in other words.
So in this pipeline situation, is there any kind of measurement that we could see results from?
Yeah, the data.
This
The
is,
data.
someone's moving up the ladder, or
Yeah.
and administrating it, it's just be a grant, so.
Yeah,
they-
Even though it's a $5, just one of the $5 increase.
So that's the preceptor.
That's the preceptor.
So this is just grant on individual,
Two
To
hospitals
the hospitals.
to identify.
and they're gonna say that we're gonna devote X amount of dollars towards childcare or tuition or training time. whatever.
Now you're talking, that is the pipeline
Yeah,
program.
that's what I'm talking about,
Correct, yes.
So, and then they have to, like any other grant, they just have to show that they're doing that.
Right, and we have a list of criteria there for prioritizing the grants, and that's, what is the employer gonna be doing to participate financially? How are they gonna sustain it? These are all things they're gonna show in applying for the grant. How much they're gonna be able to leverage scholarships, their ability to retain the
How do
workforce.
we stop UVM from sucking up all the money?
It's a good question.
Right, and this is relying on, on VSAC using these criteria. One of them is geographic location to ensure access for nursing staff across Vermont.
So is it safe to say that you guys didn't really spend a lot of time on where this was gonna be housed? Because it was clear from VSAC's testimony, they didn't know a lot about the program.
And didn't audit.
I would say that that's fair. We were sort of working in sync with trying to talk to some of the different potential home sites for all of the different programs. And as we developed ours, we didn't have people come back in and testify again.
Right.
So,
Fair, okay.
Did the ASAC people or AHAC people, did they testify?
AHAC testified, I think, early on with what they thought the priorities should be. But they are more focused on sort of earlier in the scope. But they were the ones who were recommending give us money to do more outreach to middle and high school students, for example, to encourage them to go into nursing fields. They had a list of recommendations.
Did the state ever step up to the plate and say we can administer these grants?
No, and we were concerned that it would not move as efficiently based on some of the other programs that we've seen, like the mental health scholarships.
Would you just to get a feel for this, we were to change this and give it over to the state and say they could subcontract and let them make that decision who's the best agency that Or do you feel you've got a mandate that VSAC do?
I don't, the only problem, the only question I would raise with that is that gonna create an additional delay point in getting it started? Because if the agency then is looking for a grantee to run it,
Right.
then that's gonna create, you know, another delay. You know, there's one line in there, I'm surprised you didn't jump all over me for yet, you just didn't see it, because we put in an admittedly likely extremely ambitious goal, which was really to try to make a statement about the urgency, and probably is not realistic. But we did say that, where is that?
Number 15, chapter report, is that it? Page 38.
No, this is that it has to be done in time to start students in the fall semester this fall, the pipeline programs. Oh, yes, page 38, C1. VSAC shall begin awarding grants expeditiously in order for healthcare employer staff to begin enrolling in nursing school programs that commence this fall. And that's probably fairly unrealistic to.
Really? Don't you think they all know about this coming down the pike? This
Well, I
gets
hope.
enacted in July, surely they're capable of,
I would hope, because, yeah.
as long as the grant application isn't too burdensome on our hospitals, which are already
Right,
in pretty dire.
I think we're just gonna have to, I hear you in terms of the delay, but there's gotta be delay when you have an unwilling administrator. There's gonna be some other
Right.
problems there.
but that would be my one concern about it, if it goes to the state to then find that, you know, then we've added a step before the money can actually go out.
Anybody else to be on bar?
Yeah, I don't know.
Were you volunteering to oversee it, Randy?
Each in our block.
Yeah, because we also, I want to know, how do we see the results of this? And what, I assume that we require the hospitals to let us know how many people they've upskilled over the course of a year.
I guess it would be the grant terms.
Right.
But it's important for us to have that.
So the next, section 23 is the nursing forgivable loan incentive program. This was one of the things, pretty sure this one, this is the loan program that was established, I believe, 2 years ago and has been funded. And has enough funds for next year, but it was really important to get it into statute. It hasn't been in statute. That's why there's only $100,000 in it, because they've got the carryover money. It's the same thing. We were very concerned about the primary care doctor workforce. They also, that is part of the base budget now. That was created 3 years, I think, ago. And so,
And VSAC, as you know, loves this program.
yes.
And they're carrying forward. They're all set on this one as far as we can tell.
Yeah, all this does is put it in statute. The loan repayment program was one of the things in the strategic plan and was part of the somewhat limited governor's recommends on. The largest of the governor's recommends out of the strategic plan was, I think, 33 million for the tax exemption piece, which the testimony we heard would not really be a significant incentive. And so we were trying to look at some of the same dollars, but put them where the testimony was indicating they would be most effective. But this $2 million on the loan repayment was one of the things that was from the governor's recommend and that we heard was positive. The one thing we added was including physician assistants, which are one of the kind of frontline positions that, you know, it's not primary care doctors and it's not a nurse.
Did you add that or another committee?
No, we added that. Or we asked for it to be added when the bill was in another committee by then. So I actually think it was Ways and Means that caught the fact that we had forgotten.
I'm not surprised. So what And the loans include federal education loans, but any kind of loan as long as it's an educational loan. Is that correct?
That's correct.
And an eligible school needs to be if it's any educational loan, it could be any accredited school, I assume.
That's right. If they're coming to work in Vermont, they can have gone to school anywhere.
Right.
The next one,
In Vermont, by the way, schools in Vermont, beside UVM, who provides nursing education.
Norwich, and then the Vermont.
VTC.
VTC, right, the largest number of sites is the Vermont State College system,
Mhm.
Castleton,
CCV.
CCV, Castleton.
And in fact, they were a little concerned that when we say all nursing schools, that everybody's included in that. Do we define all nursing schools somewhere in here? I didn't see it.
It's any nursing school in Vermont, yes.
Okay, so that, because VSAC was a little, not VSAC. The state called, we heard testimony from CCB and they were a little concerned that they wanted to make sure they were included. So that's assumed in that?
Yes, that is absolutely.
We're gonna hear from,
Yeah.
some colleges.
And
when we counted things like the nurse faculty positions to come up with the, estimated amount of money and so forth, it was including all of those sites. And we had testimony from each of those.
And the key additional pipeline money, Randy, is in the CTE money that's in the budget. The CTE, of course, has many of our CTEs have good nursing programs. And if you take dual enrollment and you end up with additional courses at VTC, for example, you could end up with enough credits to begin right away a job as an LPN or and then you could be upskilled. But it's,
Well, I know one of the things we talked about also at one point last year was military, people leaving the military who are nurses and medical professionals and other key skills.
I wonder where they're going.
Well, it doesn't seem to, the last thing I've seen and stuff we've dealt with this year is the concentration on the National Guard, including at Fort Drum, which makes not a lot of sense for medical because they don't have a hospital there.
Right.
But that's another subject.
But this creates an opportunity for people with any background to have loans forgiven, although you come from the military, you have to.
So we actually talked about this a little bit yesterday. Is there any discussion as to whether these loans that are going to be forgiven, I know they have to be educational loans, but do they in any way have to be tied to medicine or nursing? I mean, if you started a loan in Greek theology, can you come in and say, I want that forgiven? Is it pursuing the nursing career now?
That may be the right person.
Right, because it's in exchange for you working in the nursing position, the presumption is you're paying off a loan for being able to become a nurse. So I would have to relook the details of the language to make sure we made that tie, but that was the assumption that because you're getting the forgiveness based on working as a nurse in Vermont.
The language doesn't, the language just simply is for education. So it basically supports your decision to move into the medical field, but you may well have had a loan from being a student who was an anthropology major. I mean, it doesn't say, but if they're now willing to work in the medical world,
We need
this
them
is
and want them. We need them and
we
want them.
need them and want them, even if they were a phys ed major.
So the next one, section 28, is the other one that's specifically focused on the nurse faculty in the schools, and it's a carve-out scholarship and loan repayment program specifically for the advanced degrees that enable you to be nurse faculty. So that's the 500,000, and all that language is just the same, creating the program and
And this,
the required.
yeah, this is where we got more
You
pushback.
say a carve out, does it work as a carve out practically, or are they two separate programs?
Yeah, I didn't mean carve out, it's actually an add-on, it's a separate, it's a new focused scholarship and loan repayment focused on the advanced degrees to become a faculty member, as opposed to the generic nursing.
So, and this is a VSAC, you gave this to VSAC 2, as I recall, because
Yes, because
they
this
are
is
not
the-
happy, they do not want to do loan repayment. They said there was already an agency doing loan repayment.
okay.
Isn't that what we heard?
They, several of these things have been.
Yeah, they do not want loan repayment work. They are happy to do forgiveness work, which they already do. And they were very clear, they did not want to be in the repayment business.
Okay, and I, this may have been an oversight. I'm noting, just looking at this, that the nursing and physician assistant loan repayment is listed as going through the Department of Health.
Yeah.
Which means that the nursing faculty loan repayment also should clearly, that one should clearly be in the same. That would make no sense to, and that's an oversight, would make no sense to have different agencies doing the same type of program.
Okay, hey, maybe we have liberated VSAC from at least
Well,
one
from the
of these.
loan repayment portion, that one is combined because the forgivable loan is actually a different term for scholarship.
Right, but DOH is the umbrella which oversees
Yes.
the loan forgiveness program.
Correct. Yes.
Got it, so let's give them repayment as well.
So the next piece jumps to, and we're starting to get into some of the smaller and not the big financial, or some of them are financial, but the budget review piece is a sort of little contentious side debate with the Green Mountain Care Board and the hospitals and also some of the frontline nursing and so forth. And that is the degree to which investments in urgent workforce issues should be included in the Green Mountain Care Board budget review.
So sorry, I've lost you.
Oh, I'm sorry, we're all the way, we've jumped to
Where's
page
it?
47,
Oh, yeah, we're on
section
section
30.
29.
budget, section 30.
Oh, section 30.
Budget review. So this is just saying that the Green Mountain Care Board should review the investments. It's not mandating that they include them, but it's saying they need to be looking at that. And number 13, which may look a little unique, it was not unique for the Healthcare Committee. The issue of the salary spread between top executives and clinical and the nursing staff, frontline workers has been a kind of thorn in the side for the workforce morale, if you will. For many, many years, we've had this request, and we felt that as a morale issue to tell the Green Mountain Care Board to look at it. We're not saying you have to, do anything. We're not authorizing anything in terms of the budget, but we're saying you should be looking at this in terms of the leadership staff.
I just didn't want to walk out unannounced. I'm going to speak to the students on the State House steps about substance use prevention.
How long do you think of it?
Probably 15, 20 minutes.
Take an umbrella.
Somebody have one? They have a covering.
They are supposed to do that as well. So,
Okay.
Good luck.
It's an hour long. I think I'm second.
Yeah, I think I've got
Most you-
15 minutes.
Okay, great.
It's a bunch of high school students that are coming up.
It's like prevention works day.
Which is
Young people.
critically important. 210 already this year.
Yes, it's exactly 70%. Sorry, Ann.
So this doesn't have any money attached to it?
No money attached, and the same with section 31, that's kind of a continuing, that's just for this year, that the Green Mountain Care Board, it's permissive, but they can exclude investments in workforce development in terms of the budget's hospital
which is
growth limits.
Right.
The next part, section 32, and I think, section 32 is about the data center, which across the board from virtually all the stakeholders, we heard how important this is. And this is really this issue of, 1 year at a time, something else pops up as an urgent shortage, and we just need to get that overall picture. And so this is to create a data center, and unfortunately, the section numbers are a little out of order because a little bit later we talk about using that for supply and demand modeling. But this section establishes that workforce center, this is where there was a lot of knocking around, we don't want it, and the Office of Healthcare Reform did agree, does need a staff person, but was not saying they needed the amount of, Department of Labor and so forth. We're saying we need 3.5 million if you want us to set this up. And
So it was originally 2.5.
2.5,
So it's now down to 1 million.
it's 1 million.
That's an expensive staff member.
Well, we had originally put, no, that's not, this is the IT infrastructure.
And where's the staff?
The staff member is on page 50 at the bottom, D, one permanent classified healthcare workforce data center manager position.
So the 1 million is.
So the 1 million, yeah, is for the IT and the person.
Yes, that's correct.
Let me ask you a question. I think, I don't know, we may have jointly served very briefly on healthcare legislative joint committee. It's disbanded, in my opinion, because the appropriators wanted control over it, didn't want to be bothered by the policymakers. Does that still go, is it HRAP or,
HRAP still exists, yes.
but you're not on that?
No,
I don't think they meet very often. There's a need for that, a committee like that constantly. During the off season.
Yeah.
So, somehow involved that committee in this issue here. Give the money to the legislature to do stuff. Okay.
so when we talked with the Office of Healthcare Reform, they requested, they said, if we're gonna do it, you need to make sure we have the authority to get information from other state agencies and so forth. So that's some of the language and the position created. Section 33 is another piece directly from the strategic plan proposals, and that is in terms of mental health licensure. Apparently, it's a bit of a mess, so we're asking them. The workforce strategic plan actually said over the next 5 years, and we said, no, we have a crisis. Over the next 5 years doesn't work. We want to know by next January what you've identified and what steps need to be made, legislatively to address barriers for licensure for mental health positions.
So
Yep.
OPR, you probably don't deal with OPR too much.
Oh, we
Do, yeah, because they license all nursing and they license, or
That's
wish
right.
they licensed everything, quite frankly, in the medical world. But OPR is, as you know, working really hard on trying, because reducing the barriers to licensure is a big workforce development, low-hanging fruit piece.
yes.
So it might
We
be.
were really, when we heard from OPR and we looked at the strategic plan, the things in the strategic plan that it said OPR should take the lead on, they have jumped in and
Yes.
are working on it. Different from anything else we heard. They were impressive in terms of how much they are already picking up on.
It's an impressive office.
Yes,
I just.
we found that.
Yeah, and I know they've made huge strides on nursing, and I would assume that would include mental health nurses too, I mean, just nursing.
Yes, these are the other treatment professionals, and
Yeah.
we added that because of the specific identification in the strategic plan,
So
which of course they were involved in developing the strategic.
I guess my question is, did you ask them how much they could sync up the nursing licensure barrier reductions that we've, I'm just punting the name of the, all state, the compacts, the
Yes.
licensed compacts. Is there any way for us to, and I guess we should ask Lauren this, but to sync up the compacts for mental health care as well?
That's a really good question. My faith in Lauren, I hope she stays for a long time,
Oh,
is that if those opportunities exist, she will be, she doesn't need direction from us to be seeing those.
Okay, well, that's something we can ask.
Yeah. Section 34 is a limited service position because it's establishing, it's to create a position to work on all of these, I referenced this at the beginning, all of these strategic plan items that need somebody to be pulling them together and saying, okay, get you guys to meet.
Yes, this is the head of the octopus we need.
Exactly, exactly. Section 35, which I briefly referenced before, what are we planning to do with the data that we create in the data center?
Well, you just move on, we always have this perennial question on 34.
Oh,
So
sorry.
you have it for the 3-year project, but at this point, you're only budgeting 170,000 for 1 year. correct?
That's correct.
But there's an anticipation that the legislature, by signing off on it, is making a 3-year commitment.
That's correct.
When I deal with our appropriations committee, a different message that if you want to do something for 3 years, even though you would like $5 million for 3 years, they're saying, well, count that as being spent all this
Right.
year.
Yes.
Oh, okay.
So we would be, our appropriations committee would rather have this be ×3.
Which is sort of what we did back with the, which one was it? We said $1 million.
Yes,
for
we've done that
3
already,
years. Yes, yes.
in the previous thing.
So
Like
section,
you did it for the emergency grants to support nurse faculty.
That's what it-
Yeah,
right, yep.
there you did it, so it might make more sense to do that here.
So section 35 is that next step, and that's just come back to us and tell us what is the methodology and what the funding needs to be to maintain a capacity to do healthcare supply and demand modeling that's based on the data center information. We would have loved to say, start doing this, but you can't do it without having that single source of information first. It was amazing how hard it was to actually find out how many professionals we have in different fields, which ones are the ones that are, you know, most, we're most facing a crisis in, and that sort of thing. I just saw in the news the other day about the Alzheimer's Commission and how the projections of, you know, catastrophe down the line.
Well, the care capacity.
And that's why we need it in one place where we can say, okay, we can see ahead that if we don't act now, we're gonna be in a crisis.
So one question I have for you is, why is the Green Mountain Care Board not tasked with more in terms of, I mean, I don't know the interplay of DOH and Green Mountain Care Board. I mean, to me, that's a kind of fuzzy thing, is
I thought it belonged in the Green Mountain Care Board.
yeah.
That's where we
I think a lot of
started.
this, actually, if Green Mountain Care Board, but then they'd be overseeing all of healthcare, and they don't.
They don't over workforce in those pieces, but they do have responsibility for the healthcare resource allocation plan, which does include workforce, but they have it only on a very limited scale. And what they do is they pull in the information that, in other words, they would pull in the workforce data center information into their overall resource allocation plan. They said pretty strongly that they didn't have the capacity or the scope to do that. They were, you know, we put in 2.5 million in the beginning budget, but they said 3 million, and the Department of Labor said 3.5 million is what it would cost them to do the data center. So this was one of those moving targets. But it seemed clear that in terms of supply and demand modeling, that the Department of Labor would be the right place to do that once the data center was up and running.
Okay.
And this is the last section, section 36. And again, that came out of the strategic plan about continuing administrative cost reduction as really a workforce. You know, if your workforce is spending less time on paperwork, they have more time for patients and you have more workforce to go around. And so that's why it was in the workforce strategic plan for healthcare. And this is simply continuing some ongoing work, but saying time to do the next step. DFR is supportive for doing this, and do not need any budget additions to do that. The hospitals were extremely concerned about this initially. I got a panic letter saying, this won't work, this won't work. And I said, well, did you read the language? It says they're supposed to explore the feasibility. The first sentence of A, explore the feasibility. They're gonna listen to you, they're gonna talk to everybody, and if it's not feasible, it's not gonna go ahead. They're not telling you to do it yet. And then they were okay.
Good, that was a good overview, took a lot of good notes. We call you with some questions, follow up, but thank you for your time.
Absolutely. Thank you.
I'm gonna move on, I don't know if I can take a break right now. Shannon, are you available if we start up at 10:30?